We would like to welcome all of our viewers and listeners to another Road to Wellness webinar. I'm Kathy Olevsky, the host of the Road to Wellness educational webinar series for the Vasculitis Foundation. I'm a patient, just like many of you, living with vasculitis. I was diagnosed with ANCA-MPA in 2008. I was in treatment for 6 years, and I'm extremely grateful to have been in remission off treatment for 8 years. I hope to help the Vasculitis Foundation bring awareness to this disease. Our webinar topic today is Cryoglobulinemia vasculitis. I'd like to begin by introducing our 3 guest speakers, and then we will turn it over to them and let them get started. First of all, we have Dr. Alvisa Berti. Dr. Berti is a consultant at the Rheumatology Department and a researcher at the University of Trento in Italy. He spent 2 years at the Mayo Clinic in Rochester, Minnesota, with Dr. Ulrich Specks, and his long-term research interest is vasculitis, I may not have said that right, from bench to bedside with the goal of improving patients' care and outcomes. And his main research access is ANCA-associated vasculitis. And we also have Dr. Divi Cornec. Dr. Cornec is a professor of rheumatology at Brest University Hospital and a researcher in Brittany, France. During a 2-year postdoctoral experience at the Mayo Clinic in Rochester, he developed an interest in ANCA-associated vasculitis as part of a research group led by Dr. Ulrich Specks. He focuses most of his current clinical and research activity on primary Sjogren's syndrome and ANCA-associated vasculitis. And also today, we are happy to have Steph Lee, who is a patient living with cryo. Prior to being diagnosed, Steph Lee was one of the only Minnesotans who did not complain about the winter, but took the day off to celebrate the first big snowfall every year. She's an avid cross-country skier and tennis player, and she loved being outside and being active whenever the season. She grew up and worked in the travel industry most of her life. So in 2012, she branched off on her own and started her own company in the travel space, Host Agency Reviews. Then in 2014, at the age of 34, she suddenly became severely debilitated with no explanation as to why. In 2019, after 5 long years of debilitating symptoms and being told repeatedly it was psychological by neurologists, Steph was diagnosed with Cryoglobulinemia, vasculitis. Her illness was a turning point in her life that slowed her down and grounded her, both literally and figuratively. She's now an avid gardener, meditator, and has picked up swimming as her exercise of choice when she's able. She works on her site with a team of 3 other talented ladies and is very thankful she decided to start her own company for the flexibility that it gives her. Steph and her loving partner and caretaker, Paul, live in Minneapolis during the summers and now move to warmer places during the winters, and always with their 2 adorable dogs, Fennec and Orion, in tow. So thank you so much for joining us, doctors and Steph. We appreciate it. And I think at this point, I will turn it over to Dr. Cornec and let you help us understand a bit more about cryo.
Thank you very much, Kathy, and thank you for the Vasculitis Foundation for organizing those great webinars on those most rare forms of vasculitis. So the subject tonight is cryoglobulinemia and cryoglobulinic vasculitis. So I will share my screen to give a few informations. So Alvise and I live quite apart in Europe, but we are really good friends, and this has been the case for a few years now. And we met actually far from Europe in Rochester, Minnesota in 2016 when we were working, both of us, in Dr. Speck's lab at Mayo Clinic. And so this was the beginning of our work together, especially on vasculitis. So we chose to define 9 main points that we wanted to discuss with you patients. So 9 main questions that could give some insights about what is cryoglobulin and how we can we doctors can try and help you. So I will give some information on these first 5 questions, and Alvise will take the lead for the second part of the talk about clinical manifestations and treatments. So first question, what is a cryoglobulin? This word seems complex, and it is, but we can recognize some clear information. Cryo for cold, and globulin, as in immunoglobulin, means antibodies and antibodies. So cryoglobulin describes an immunoglobulin or an antibody that clogs when it is exposed to cold. And this kind of protein that we can detect in the serum of some patients are the hallmarks of a disease called cryoglobulinemia or cryoglobulinic vasculitis. How do we detect cryoglobulins? Because this is rather important to understand why it's sometimes difficult to diagnose the disease. The lab test is a bit peculiar because the blood that we take to the patient has to be sent to the lab at 37 degrees Celsius at body temperature. If this is not respected, the test won't be positive. So it's very important and quite specific. And this could explain some variability in the results of the test. And when the blood arrives in the lab, it has to remain at body temperature until the serum is separated. And then it is exposed to cold. And after usually a few days, we can observe this kind of cryoprecipitate in the tube. So this technique is rather complicated and long, and this could explain why the results can be variable from lab to lab. Next questions, are there different types of cryoglobulins? I won't get too far in those details, but yes, we can define 3 different types of cryoglobulins based on their chemical properties and the exact composition of the cryoglobulin. But this is important because it is clearly associated with the causes of cryoglobulinemia. The type 1 cryoglobulin is usually associated with B-cell proliferative diseases, basically blood cancers or lymph node cancers, such as lymphoma. Whereas type 2 and type 3 cryoglobulins are mostly associated with other diseases and form what we call mixed cryoglobulinemia. And the underlying conditions that can explain the appearance of those cryoglobulins are mostly hepatitis C, some systemic autoimmune diseases such as lupus or Sjogren's. And when we don't find another cause to the cryoglobulin or an underlying condition, we call it essential mixed cryoglobulinemia. And 5th point we wanted to see tonight is how frequent is cryoglobulinemia. Actually, it's one of the rarest vasculitis form. It's a very rare condition, whatever the cause is. It's so rare that it's difficult to give precise numbers about the frequency of the disease. And that's also explainable because the underlying conditions are very variable in different parts of the globe. Of course, hepatitis C prevalence is highly variable between different countries, and the frequency of this infection is also variable according to time. And if we want to think about the frequency of cryoglobulinic vasculitis in Sjogren's and lupus, for example, we have to realize that CryoVas is a rare complication of rare diseases. So we see a few patients every year, and it's really what we can call a very rare condition.
So the clinical manifestation of cryoglobulinemic vasculitis varies substantially among the different types of cryo, type 1, type 2, and type 3, as Dr. Cornec showed you before. As you can see at the beginning of the slides, at the top of the slides, the type 1 cryoglobulinemia classically produces signs and symptoms related to vascular occlusion by the cryoglobulin precipitation into the blood vessel, leading to ischemia of the body extremities and vascular manifestations such as skin ulcers or necrosis. This is due to the monoclonal cryoglobulins that form aggregates that increase the size with the cold temperature. Mixed cryoglobulins form immune complexes instead, as you can see at the bottom of the slides. When the temperature decreases, the complex size increases and may precipitate in small and medium-sized blood vessels, leading to leukocytoclastic vasculitis, which is an hallmark of the disease, like the palpable purpura, the skin vasculitis that you can see in the picture here. The disease expression is variable, ranging from mild to severe clinical symptoms, or to life-threatening complication, such as widespread vasculitis or glomerulonephritis, which means severe kidney disease. Manifestation often fluctuate over time with spontaneous remission sometimes and exacerbations. As mentioned before, skin involvement is reported in up to 86% of the patients in the type 1 CryoVas on the left part of on the screen here, which is characterized by more severe cutaneous involvement, such as necrosis and ulcers. Extracutaneous disease include arthralgia in almost 30% of the cases, peripheral neuropathy in up to 45% of the cases, and kidney disease in up to 30% of the cases. When the percentages of the cryoglobulin, of the circulating cryoglobulin, is high in type 1 CryoVas, symptoms of hyperviscosity may occur. It means that the blood flow is packed, is slowed down within the blood vessels. So you can have symptoms like vision blurring, confusion, headache, vertigo, dizziness, and something like that. In contrast to patients affected by cryo-1 vasculitis, mixed CryoVas have different clinical manifestations, which are the classical purpura, so an orthostatic purpura, especially at lower extremities, which is due to cutaneous vasculitis, constitutional non-specific symptoms such as arthralgia and fatigue, and sensory changes or weakness due to the peripheral neuropathy, most frequently distal sensory motor polyneuropathy, which means that there are multiple persistent distal nerve disease with the numbness, tingling, and burning sensation. And only rarely there could be deficit of strength. Kidney involvement is present in more than 30% of the cases in mixed cryovasculitis, and usually it manifests with a specific type of renal involvement, which is membranoproliferative glomerulonephritis, which is seen in the majority of cases, about 80%. Patients with renal involvement usually have protein and blood in the urine and a variable degree of renal compromission. Finally, GI involvement, lung and cardiac involvement are quite rare. So how can we do the diagnosis? The majority of the people with cryoglobulins, with circulating cryoglobulins, are asymptomatic, and cryoglobulins may be an isolated serological finding. When patients develop signs and symptoms, the one that we just mentioned before, this is defined cryoglobulinic vasculitis. So there are no defined diagnostic criteria. We generally do the diagnosis of cryoglobulinic vasculitis as follows. The demonstration of an elevated cryoglobulins, such as more than 1%, and a clinical surrogate of cryoglobulinic vasculitis and or an histologic proof of cryoglobulinic vasculitis. So in addition to the clinical pathological features such as purpura, leukocytoclastic vasculitis, and multiple organ involvement, other important lab tests that may help for the diagnosis are the rheumatoid factor detection or the low serum complement C4, an underlying infection HCV in particular, HPV, etc., and other specific autoimmune and hematological lab tests to assess for secondary forms of vasculitis, secondary to hematological or autoimmune diseases. In the case of clinical findings suggesting of CryoVas, and without the presence of circulating cryoglobulin, which is something that might occur, the test should be repeated since, as Divi showed before, this could be falsely negative due to the technical handling of the sample. Or more rarely, this may represent a transient condition during the natural history of the disease. The data on the prognosis is lacking. The curves on the slides that you can see on the left part of the slides represent the survival of the patient with type 1, the dotted line, and type 2, 3 CryoVas. So first of all, also in the general population, these curves decrease over time, so that's normal. Second, these general curves do not take into account the severity of the disease. So it does not apply on the single patient, but instead this is supposed to give a general idea of the survival of the whole group of the patients with CryoVas, type 1, type 2, and type 3, of course. So here are represented the retrospective data of some French studies. Overall, the prognosis of the type 1, it's better. That's what it means, this dotted line. It's about 87% after 10 years. The cumulative 10 years probability of survival of patients with mixed type 2, type 3, HIV or non-HIV is a little bit worse as compared to the type 1, which means that, and it's about 60–70%. So it's important to understand why this patient has an unfavorable outcome. This was due to infection mostly in both HCV positive and HCV negative group. So we need to be careful in this patient, particularly for those under immunosuppressive therapy and higher doses of corticosteroids, which is a risk factor for infection. Other causes are the progression of the liver disease in the HCV positive. So it means that one patient that have chronic hepatitis may have an unfavorable outcome due to the progression of the liver disease or for the vasculitis, particularly when these affect kidneys. Third point, the most important one, is that these results on the prognosis were derived from heterogeneous and not very recent studies, as you can see here from the dates in which these studies were published. So these data were produced before a more widespread use of Rituximab, a potent immunosuppressive agent, and the direct antiviral agents for the HCV form were introduced to treat cryovasculitis. So in the next few years, the prognosis of CryoVas may change. So in these slides, we summarize the therapy for cryovasculitis according to the recent literature. This is valid for most of the cases, but of course there might be exception to this algorithm. The treatment for the type 1 CryoVas, it's more the treatment of the underlying hematological disease, and this is based on polychemotherapy, but specific treatments might be added, such as glucocorticoid, GC in the figure, or plasmapheresis can also be indicated. So, for instance, when symptoms are severe, plasmapheresis is usually indicated at onset of the disease to achieve a rapid control of the cryoglobulinemia. For type 2 and type 3, if HCV positive, new antiviral agents should be considered as the first line of therapy. They are usually administered for 8 to 12 weeks for the patient with mild to moderate disease severity, without any immunosuppressive agents. Low dose of corticosteroids, glucocorticoids, may be also added to help the minor inflammatory signs, such as arthralgia or purpura. In patients presenting with a more severe disease, like an altered renal function, which is the MPGN. You remember the glomerulonephritis that I mentioned before, an important peripheral nerve disease, so mononeuritis multiplex that you've seen on the slide, and skin ulcers and necrosis. In these patients, an induction phase with rituximab and with or without glucocorticoids is often necessary, plus the antiviral agents. For patients presenting with life-threatening disease, so the rapidly progressive glomerulonephritis, LPGN, which means severe kidney involvement, digestive, cardiac, lung involvement, and central nervous system involvement, the CNS. Plasmapheresis can have an immediate beneficial effects and must be started the sooner the better, in conjunction with immunosuppression, and then in these cases, antiviral therapy should be started after the critical phase. So, to sum up, we discussed about the cryoglobulinemic vasculitis, a quite rare disease, with clinical manifestation ranging from mild to life-threatening manifestation that reflects the cryoglobulin classifications, laboratory classification. Diagnosis can be complex sometimes, and this may lead to diagnostic delays sometimes. And finally, prognosis will likely change thanks to the recent therapeutic advance.
Okay, so at this point, I think what we would like to do is thank you both for your presentation. I enjoyed and learned so much, as I'm sure everybody else did. I think Dr. Cornec and Dr. Berti, we're going to have a little question and answer session, and you all can talk to Steph a little bit. She's going to tell us a little bit about her journey and maybe ask you all some questions. And so I think we'll move into that. So we should start with Steph. Why don't you tell us a little bit about your journey with cryo?
Certainly. So definitely a journey. Like we said in the intro, I was a really, really active person. And around when I was like 33 years old, I started getting some symptoms I just thought was about getting older. I used to be a really great sleeper. Like, people used to be like, Steph fell asleep upside down on the couch. Like, I was a great sleeper. And I started noticing I was having a lot more trouble sleeping. And I was having like leg pains at night that were really hard to pin down. And I started fainting randomly, which was, of course, very concerning. But then the doctors had told me like that it was like a common thing for younger people to have this type of fainting where it just sometimes happens. And then, so I didn't think a lot about it. And then it wasn't until later, probably about a year after my symptoms started, I was having a lot of random pains in my body too. I was going to ski practice, and I was on a women's team, and we were starting, it was in the fall, but we were getting ready for the winter season. And I was just so incredibly fatigued, which is not like me. And I like pulled up into the parking lot and saw my ski team like getting ready to exercise. And I pulled myself out of bed to get there. And I was like, I just can't go to practice today, which has never happened in my like 33 years. I was like, so I turned around and went back home. And then shortly after, I started like my legs both went numb at the same time. And they just were like really tingling. And I went to the doctor and they couldn't find anything. And they also told me that's not really how neuropathy presents, which at this time I'd never really been in the medical system. So I had no idea what any of that meant. But yeah, then it got worse. And then I started, they told me if it starts moving up into your face or like a side of your body to let us know. And then it did start moving up into my face. I think it was my right side of my face. And the nurses told me to call an ambulance, which freaked me out. And so they came into my house, and I failed I just very distinctly remember they told me to put both arms up and close my eyes. And I closed my eyes, and then I opened them, and my right arm had dropped, and I had no idea that it had dropped, and it freaked me out. And then they were like, we're going to just take you to the hospital. It's not a big deal. And so I went in the ambulance, and in the ambulance, they had me like stick out my tongue, and something must have happened with that. I don't know exactly, but they're like, we're just going to turn on the lights. It's not a big deal. And I was crying hysterically at this point because I was really scared. And I got to the hospital, and it was really cool because now that I've been in the system a long time, I know this is not normal, but having not been in the system and watched a lot of TV, I thought this was how you got into the ER a lot. So it was like, they opened up the ambulance doors and all these doctors came out of me and they're like taking things off of me and like putting things on me. And I'm like, oh my gosh. But then they were like, there's nothing wrong. You didn't have a stroke. Like, you're just fine. And I was like, that was super weird. So I was told by multiple neurologists that I needed to see a psychologist, which was, of course, it was one of the most traumatic events that has happened during my journey, is being told this is in my head by doctors. But then I finally saw a rheumatologist, because it's really tough to get in as a new patient. And so about 9 months after my symptoms started, and I had been in bed pretty much for 9 months, I was very weak, had a lot of trouble walking on my own. And some days my legs wouldn't work or my arms wouldn't work. I would have trouble lifting up a spoon. It would really fatigue me. It felt like, when I was doing my 40-kilometer ski races and I was going up a hill, like the burning in my arm was so similar to lifting like a spoon to lift my cereal. So they tried me on prednisone, and I was like back to myself within like 3 days. I was like, oh my gosh, like this is amazing. And so then they started me on immunosuppressants. They didn't know what was wrong with me, but they started me on things like Plaquenil and then added azathioprine. And then my rheumatologist at the time did something a little bit, as my symptoms kept coming back, despite the immunosuppressants. She added on Cellcept to that, which I guess is pretty unusual. Anyhow, so we went down to the Mayo Clinic and they told me, you're on way too many immunosuppressants. Because one of the really weird things about my cases is not only is cryo really rare, but my type of cryo, which is the essential cryo, is really rare. And I never had high markers. Like, a lot of people will have inflammation markers that show, and none of mine were ever, even during the worst flares, were ever positive. So it was really difficult to nail me down. So at the Mayo, they suggested I go off my immunosuppressants, and that I didn't actually need to be on those. So I went off of them. And then about the time they wore off, like 6 months later, I started having really bad symptoms again. I started fainting, but they went on like that for a month and a half. And the doctor finally, my rheumatologist said, like, this isn't normal. I think you need to go to the hospital. And I wasn't in pain. So I went to the hospital, and they admitted me to try to figure out what's going on. And the doctors in there said, the rheumatologist team came in and they said, I think we've been looking for horses, and I think it's time we start looking for zebras in your case. So they did tons and tons of testing. Finally, one of my markers was high. I think it was like my rheumatoid factor for the first time ever. And then it wasn't like, it's really interesting that what actually like broke my case open was I had been up in northern Minnesota prior to being admitted, and there was like bugs out, like mosquitoes. So I thought that I had some mosquito bites on my foot, because there are these really tiny pinpricks on my foot. And they said, like, is there anything abnormal that's happened? I said, oh no, there's just these couple pinpricks. And then they said, like, we'd like to take a biopsy of them. And they took it. And it was on a part, I lost feeling in my feet and couldn't feel them. So it wasn't a big deal. I was like, go for it. And they came back and they were like, you have leukocytoclastic vasculitis. And I was like, okay. And then they tested me for all the vasculitis, the types of vasculitis, like the ANCA vasculitis, and nothing came back. So they were like, we're just going to put you on high dose prednisone and see if this goes down. They were a little worried because of the like not being able to feel my feet in the hospital. So I went home, and then they ended up doing an EMG, but it was like 2 months out. And they found out that I had like motor and sensory problems with my nerves, and some of my nerves weren't working in my foot. So then they called and they're like, this is a pretty big deal. We're going to put you on higher dose prednisone, like at 80 milligrams. And we also want to do a nerve biopsy to see if this is in your nervous system, if it's vasculitis. And so they put a special neurologist on my case that I guess specializes in autoimmune diseases and more unusual cases. And he said he'd gone through my whole file, which is a huge feat. And he was like, I noticed there was one type of vasculitis they didn't check you for, and it's cryo. He's like, so I'm going to run this test. And they ran it and it came back positive. And he was like, there's a lot of false positives, which isn't, I don't think actually what happens, but he's like, there's a lot of false positives. And so we're just going to run it again. I don't think you actually have it. And then he ran it again and it came back positive. He's like, you actually have cryo. So that's kind of been the journey. There's been a lot of heartache, many tears along the way. It's been a very difficult journey, but now they started me on Rituxan, and that seems to have kept the disease better under control. I still struggle a lot, but my bad days aren't as often, and my pain levels are down quite a bit, and my flares don't seem to be as serious. So I definitely feel like my quality of life has improved the last year and a half. And that's kind of, my 6 or 7 year odyssey wrapped up into like 10 minutes.
Steph, thanks for sharing that. I think I'm going to let Dr. Cornec and Dr. Berti see if they have any questions or comments for you.
Yes, thank you very much for sharing your journey, Steph. And I think what you just told us really reflects the difficulties we have to sometimes diagnose rare forms of diseases, and how the lab tests are not always perfect, and especially when all the features of your disease are subjective. Like the doctors don't find anything bad on the different tests. Or it's sometimes very tough to make to the diagnosis. So that's probably why it took so long. But you kept seeing different doctors, and at the end you had some maybe not good news, but at least a diagnosis and a solution could be proposed.
Yeah, I was really glad to get a diagnosis, and because it's hard when you don't have a diagnosis, because, especially when you're in your file, you have that it's psychosomatic and things like that. There can be like some prejudgment when you go into like, I will say it's only been neurologists that have said this to me. But it was relieving to actually have a diagnosis, because even though I knew I wasn't crazy, it was also like, how else is this stuff happening? Like in the beginning, for a while, I was like, maybe this isn't, somehow I'm causing this with my, I don't know, like my brain power or something. And there's a side of me I just don't know. And so there was like a lot of soul searching in the very beginning on what's actually going on. But I am very lucky. I have a really supportive group of family and friends that helped me through the really tough times.
Yeah, thank you so much for sharing. So, thinking back again to your journey, I believe that this has been very frustrating, not having a diagnosis for such a long time, and you commented on this. But once you get the diagnosis, did you ever hear about cryovasculitis? Did you know something about this diagnosis once you have it, or how did you deal with it?
Well, you're going to like this. So I didn't know anything about it. And I'd read about, I am like a big researcher, so knew nothing about medical stuff, but definitely have like a partial medical degree now through all the like studies I've read through. So as soon as I like heard about like cryoglobulinemia, like I immediately went out and like bought books and like, so on my desk, I have like a bunch of books on. So I was like, what is this? Like, I want to learn more about it. And it was honestly really disappointing, because there's not a lot of information on cryoglobulinemia in general. And especially like if it's not coming from a lymphoproliferative disorder or from hepatitis C, there's like nothing on essential cryo, except for I found one study, and I noticed Dr. Terrier, you cited him on one of your slides, Dr. Berti, and I wrote him and I was super excited. And he never wrote back, and it might have been because like in the subject line, I was like, I'm your biggest fan. But yeah, I haven't heard back from him. So if you're having to watch Dr. Terrier, you can check your email. I may have gone into spam.
Well, thanks, Steph. I appreciate that. That was quite a journey that you're still on, but thank you so much for sharing that. I think what's interesting now is we have some questions both from you and from other cryo patients. Yes, there are some other cryo patients in the world. And we're going to ask Dr. Berti and Dr. Cornec some of these questions. And, if there's something that happens during that you want to say, feel free to chime in. But I'm going to start by asking Dr. Cornec, this first one from a patient. Does every diagnosis of cryo always involve a cryo blood test, or would some imaging be used for this form?
Yes, this is a really important question because we already discussed before the variability of the tests and the technical difficulties we sometimes have to detect the cryoglobulins. But it's still one of the major clues to make the diagnosis, as Steph told us just before. That was the point when her journey changed, when we detected this cryo. So in most cases, we are able to detect this protein, this globulin. In rare forms, for example, of kidney disease, the diagnosis can be performed on the biopsy directly. The kidney disease of cryo is very specific on the biopsy. So in some cases, we can make the diagnosis without detecting the cryo, but this is really infrequent.
Okay, and I actually have a question. I think Steph might have posed this question because it says, I started Rituxan in 2019. I get it every 4 to 6 months. Often my cryo levels rise sooner than the 6 month mark and I start having symptoms. How long does it usually take cryo to go in remission with Rituxan? And she says, I'm also on Plaquenil and azathioprine. And if it doesn't go into remission, what are the options? I've tried Cellcept, Enbrel, and Humira in the past.
Yeah, that's a tough question because as we say just before, we don't have much data out there on the treatments. So we can think by analogy to other diseases in which we also use Rituximab. And so in most cases, the duration of the action of Rituximab lasts for between 6 and 12 months in those different diseases. So very likely in cryo patients, it should be the same. But in some patients, we can see B cells coming back earlier than the 6 months time point. And so if the clones that produce the cryoglobulin come back at that point with the first B cells, maybe it's sometimes necessary to give more often than every 6 months. But in most patients that I treated, I used 6 months intervals, and the symptoms did not come back before each infusion.
Okay, I hope that answers your question a little bit, Steph, at least. So thanks, Steph. Thanks, Steph, for sharing that with us. I think I'm going to jump into a couple other questions. It looks like you may have also submitted these, and we're grateful.
This is my MO in life. Oh, it's Steph again.
We're grateful for the questions to help educate. So I think we'll move to Dr. Berti, if you help me with this one. Does essential cryovasculitis present any differently than any other types of vasculitis in the lungs?
Well, let's start saying that lung disease in cryovasculitis is quite rare, but maybe probably overlooked. So the most reported lung involvement here is interstitial lung disease in cryovas, often with subclinical alveolitis, which means that the lungs are inflamed. And the symptoms that usually associate with these conditions are dry cough, pleural effusion, sensation to be breathless, obviously when the lung involvement is present. But as compared to the other vasculitides, small vessel vasculitides, which is the group of vasculitides that encompasses the cryovas vasculitis, such as ANCA-associated vasculitides, in cryovas, lung involvement is significantly less frequent. So that's not a classical manifestation.
Okay, Thank you. I know it's so complicated. And another question along that same topic from Steph and another patient. So this was a similar question. So are you aware of any, and this is for you, Dr. Berti, are you aware of any current research studying essential cryo? The info that we found is that they found more often than not pertains to the Hep C cryo or type 1.
Well, yes, there are studies on non-infectious or non-HCV CryoVas as well. The reason why there is not so many, at least before the new antiviral agents that we now use for HCV, is that HCV CryoVas accounts for 80% of the mixed CryoVas, while only 20%, the remaining 20%, so only a minority of the cases are non-HCV cases, such as in the case of Stephanie. So it means that these are rare diseases, so it's not so easy to organize study. It's not so easy to recruit patients, and that's one of the reasons. There are actually several retrospective studies on non-HCV CryoVas, especially from the French group, which is very active in this sense, and also from other Italians and other European groups. For instance, the studies that assessed clinical presentation or baseline factor associated to the poor prognosis have been identified by these retrospective studies. And there are also prospective studies on therapeutic strategies for non-HCV CryoVas, such as the Rituximab, the one that assessed the efficacy and the safety of Rituximab, which are still ongoing or recently completed, both from the American and European groups.
Great. Thank you so much, Dr. Berti, for answering that. I know that was a very personal question for Steph, and she needed that answer. And, you know, at this point, I just want to say thanks so much to both of you, Dr. Berti and Dr. Cornec, for sharing your presentation and answering our questions today. And Steph, thanks for sharing your very personal journey today. We appreciate it.
Thank you.
Thank you, Kathy.
Thank you.
I also want to take a second and thank our sponsors, ChemoCentrix, Genentech, and Amgen, because they support our Road to Wellness webinar series, and they're helping the Vasculitis Foundation provide these valuable educational webinars, and they support our commitment to patient education. And this year, watch for even more disease-specific webinars.